Samajina, mercado. Mercado.
Any reportable activity? The other team members, do you have any reportable activity? So 2 people are missing. Pamela is R2, so we need at least 4 at once. Saturday KDT. Any reportable activity on Saturday? No. But we have a low. Yes.
So it should resume. Okay, you can accept and that.
Saturday night. Any reportable activity? Sunday DTT, Sunday day DTT.
He initially presented the survey history of progressively worsening importance of preventive gastric pain and did not have a test finding. And identified this process as examining smoker of tachycardia and also just track, otherwise known as the other chronic mental illness. And he was admitted to the Harrow Hospital. And he was being managed for MI and also with antibiotics for the blood fungus for practice. And he's referred here for hospital intervention. Upon evaluation in the ER, the BP was ranging from 100 to 200 systolic and 70 to 80 diastolic. And pulse rate was, he was tachycardic to the level 114 and 120. And he was tachypneic and maintained tachycardic with 6 liters of face mask initially. And special findings on chest, he had low onset bilateral practice initially. And he had positive signs of food convection in the abdomen, otherwise no edema. And he was admitted to the CCU. Investigation from the report showed ACD was anterolateral escalation ST elevation was troponin was from the referral 9,980, was 550 times elevated, and the ECG showed ischemic dilated cardiomyopathy was reduced to ejection fraction 38%, and also articular thrombus. And he had a creatinine from the referral, creatinine was 1.1 initially, and the liver functions, liver enzymes were elevated 2.5 times. And we did bedside ultrasound, and he had multiple lines, and also Addis was congested, so he was admitted to the CCU, and the management of the anti-ischemic and antiviral has continued, and safety vancomycin initiated. Initially, was challenge was last 40 milligrams ER, and we was told that he had 100 ml of urine, but after admission, he had no urine output, and last it was escalated to 100 milligrams. HCG was also added. But the chest condition was worsening gradually, and also he couldn't maintain saturation 50 liters of face mask, and he was agitated. So CPAP, he could not tolerate the CPAP, so overnight he was intubated, currently on ACDC mode with peak of pain and FiO of 80. Making saturation now, he's on pressor. He could not maintain BP after midnight, so he was initiated on pressor, and currently has around 500 ml of urine. 500 ml over 6 hours after 200 milligram last.
No arrhythmia?
No, not the pulse rate was maximum was 120, and we still have a segment elevation, the ECG monitor leads, and the repeat troponin is 35 times elevated, and we still go waiting on the organ function test and optical electrolyte.
So, cardiogenic.
Maybe what is the total duration of the unit?
Campaign starts 12 days. Yes.
The possibility is either that concentration about that those conditions will be sometimes normal. So she could have chest finding could be COVID because injection fraction in this patient is 38. And then he has either new extension of the nerve or mechanical complication. The injection fraction 38 will not persist.
Rapid antigen was done, it was negative of the ER. And yes, just immunity, it shows concentration and also bilateral therapy and not. But he has concentration, that's why we initiated antibiotics. And updated the CPC also showed leukocytes of 30,000 is introduced predominant. Leukocytes is 1,000 rounded, but we initiated antibiotics.
What is the age of this ECG? Was it done?
ECG was not done, we could find the paper, but we did ECG at the ER, and it was similar from U1 to B6 as the elevation. No.
About the renal failure and post-dialysis, the condition, and if you
Yes.
try to explain identify the condition, which is that kind of patient for dialysis.
Yes, we the cardiac side and also renal side is condition. And so we wanted to optimize the dialysis and we took the creatinine, we sent for repeat creatinine, then we shall not go on.
Was it going to work at the
No. There's only for manage for the MI and for the moral campus. We initiated antibiotic care.
Then
I noticed too, the one from the report. That's sent out.
it's exactly called probably is it severe PE. Yeah, it's only you said cardiac movements, but they're the same.
Any other reporter? Okay, thank you. Last time we had a discussion on anticoagulation plus antiplatelet therapy. So the recommendation is if patient requires pause of them during acute event, the triple therapy can be continued for 1 month, 2 weeks to 1 month based on both thrombotic and bleeding risk. If patient has high bleeding risk, 2 weeks, then if thrombotic risk is pertaining 1 month. After 1 month, one of the antiplatelets have to be discontinued based on also risk scoring. Then the patient can be continued with anticoagulation and antiplatelet for up to 6 months to 1 year based on thrombotic and bleeding risk as by assessment. But after 1 year, based on the APIRE trial and other recent evidences, after 1 year, anticoagulation would be enough for both PE, for both the MI and also the if atrial fibrillation or stroke, if there is another indication for anticoagulation. Yes, the guidelines are also recommended.
Which anticoagulation is anticoagulation?
So it depends if patient has PCI done, we continue with clopidogrel. More or less, clopidogrel is the antiplatelet that will be continued for 1 year. Then after 1 year, if possible, the NOACs, the studies were done with NOACs. NOACs monotherapy was shown to be no adverse event, but the thrombosis risk was NOAC plus aspirin versus NOAC only. Thrombosis risk is the same, but bleeding risk was high with the NOAC plus aspirin. So NOAC would be continued for the rest of Saturday night PCT, Sunday night PCT. Any reportable activity?
It is a very short communication with the diagnosis of heart failure, secondary chronic multiple severe in March. It's stated by atrial fibrillation, fast ventricular response, plus urinary tract infection, and plus has INR supratherapy range after she is a non-cardiac patient for the past 3 years, and she is on C 40 milligram per daily. We talk about 16.5 milligram per daily and 5 milligram per daily. Based on intensity monthly 5 milligram per daily. And currently she presented with palpitation, shortness of breath, and bilateral chest pain of 1 day duration. And she has also one complaint of bilateral flank pain and dysuria during urination. Otherwise, she has no fever, cough, and she has also pain currently. And on physical examination, blood pressure is at emergency was borderline 9/50, and at work pulse rate it was range 150 to 164, which is regular, irregular, and respiratory 26, temperature febrile. After admission, the blood pressure 150 by 175 and pulse rate 131, regular. Pulse rate, respiratory rate 26, temperature 36, and the other pertinent finding is cardiovascular system active recorded, and there is murmur in the MR and regular sound, and other is bilateral CV tenderness. And she investigated with CBC. CBC is normal line and urinary national repelling. The INR was 1 week ago. It was 10.9. And before that, it was 4.1. It was determined different lab, and that is why she stopped what for. Then subsequently, she managed to get initially with digoxin 0.5 at emergency. 0.5 milligrams of 1 dose was given, and subsequently the pulse rate is reduced to 120, 124 to 164, and subsequently outward 120, and now in the morning it is 100.
Towards it,
Yes. She has dysuria during urination and she has severe tenderness, bilateral severe tenderness. But the urine analysis is normally clean and syncytial asthmacytosis, but still she has severe tenderness.
Ultrasound, abdominal ultrasound.
was really good at this stuff. Urine. The low blood shows is she marshal?
She's not much.
That cut in the drug is one of the first marginal low blood. So the best way is to control the rate.
It is still high, 120 is high for babies.
What is the last blood pressure?
Blood pressure,
This time.
yeah, under 50/7. Usually it was borderline when the level of under.
You can scan it. That was to control the best way to control the symptom and the vital signs. But I think this area is an education for I don't know what the renal people.
Yeah, but only.
It comes during time.
Okay, thank you. Today we have update lecture on asthma COPD overlap.
Good morning. I'm going to talk about asthma COPD overlap, which is one of the contentious issues in pulmonary medicine. So really, I wanted to highlight what is asthma COPD, which is a very new concept introduced to pulmonary medicine recently. So the first issue of asthma COPD overlap was started on in 2012. So people understand there are patients who behave both diseases. So they wanted to put it in a different way. And then this understanding came into picture. And then in 2014, a consensus guideline was developed by Gina and Gold. Gold is expert which work on COPD. Gina is expert who work on asthma. So since in 2014, there is a consensus that asthma COPD overlap is considered as a different entity. But this evolved into 2018. This is not a different entity, rather asthma COPD occur together and then complicate things. So that is a clear understanding. And then the evolution of asthma COPD overlap, or what we call ACO. This is the outline of my presentation. I'll go on some definition of asthma COPD as well as also ACOs. What is the prevalence of this disease? Pathophysiology, clinical presentation, diagnosis, management. So as you know, asthma is a heterogeneous disease. It's not a single disease, rather it's a heterogeneous disease with different pathophysiology which come into causing of chronic airway inflammation. The hallmark of asthma is this chronic airway inflammation, which results in pulmonary symptoms like cough, shortness of breath, and wheezing. And they have also variable airflow limitation, which varies. There is airflow limitation, but this airflow limitation is vary in terms of time, in terms of intensity. So this is the current definition of asthma. COPD is common, preventable, and treatable disease that is characterized by a persistent respiratory system. So one of the key definitions of COPD is treatable and preventable disease. Previously, COPD was labeled as a cancer. It was not considered to be a treatable disease. Now, COPD can be preventable as well as also treatable. It's the third leading cause of death in the globe. So it's characterized by persistent respiratory symptom, and it's caused by exposure to noxious gases and noxious substances which injure the airway. So it is basically injury to the airway or alveoli because of exposure. Okay, because of exposure. This is the gold definition of COPD. So when you see the two diseases, when you characterize asthma is a disease which can occur in a year, typically before age of 20. Variation of symptoms in terms of intensity, in terms of severity. There is worsening of symptoms during early morning and the evening. There are also known triggers like allergens, occupational factors, emotional disturbances, some drugs, and so on and so on. There is also family history of asthma in some of the individuals. And then there is also personal history. And then when you investigate, the patient has reversible airway disease, and then chest X-ray usually normal. In case of COPD, usually the onset of age is usually above 40. Don't consider COPD less than 40 years. There is persistent symptom of respiratory symptoms like dyspnea and cough. They have with sputum production, so the symptoms are persistent. Even though there are some variations, some improvement in terms of symptom intensity. Otherwise, there is persistent symptom once the patient diagnosed to have COPD. And then some of them have previously diagnosed COPD, and then there is fixed airway obstruction in this group of patients, and then X-ray shows there is hyperinflation. In terms of inflammatory markers, there is also difference. In asthma, the main culprit in terms of inflammation is eosinophils. There are eosinophilic induced asthma. There are also allergic asthma which pass through eosinophilia. There are also non-eosinophilic asthma which is mediated by type 2 helper cells. But in COPD, the main inflammatory cell is neutrophils. That's why usually patients with COPD have fixed airway obstruction. The other is CD8 lymphocytes are the other main player of inflammation in COPD. So all those are differences in terms of pathogenesis of asthma and COPD. But if asthma is poorly controlled and poorly treated, patients behave like COPD. They will develop fixed airway obstruction. There are also COPD patients who may behave like asthma with reversible airway disease. This is when they are mediated through eosinophils, because there are some patients who has eosinophilic phenotype of COPD. So this is the natural course of COPD in asthma. So as you can see from this figure, in COPD, lung function decline starts before normal decline of lung function. In case of asthma, the decline starts when a normal decline happens. Normally, we believe lung grows up to 25 years, stable up to 35 years, and then start to decline each year after 35 years. And then in some patients, in some individual, decline may start even early. In some individual may take longer, like arthritis and so on. So, as you can see in COPD, the decline starts before normal decline of lung function starts. This is really one of the factors you should have to understand. So how can you define ACO, asthma-COPD overlap? So Gina defined this as a collective descriptive term, which is the presence of persistent airflow limitation in a patient who has both asthma and COPD feature. So this is a definition of GINA, which is expert opinion from asthma group. So this is not a definition of a single disease. So they say this is not a single disease, rather overlap of asthma and COPD in a single patient. So the patient behave differently, but they have two different diseases occurring together. From COPD team, ACO is defined as, they emphasize that asthma and COPD are different disorders, although they may share some common pathophysiology, but they occur in the same patient. So that is the whole definition of the two groups. So this creates difficulty in terms of defining ACOs, because the danger of seeing ACOs as a disease entity may blur the difference between COPD and asthma. That is really a major challenge. If you define as a different entity, so there is no landmark between asthma and COPD. So that's why this is also one of the challenges. That other is ACOs definition are being applied in various studies in a different way. So that's also, there is no consensus definition also used in different studies. That's also another major challenge. The other is most of the studies in asthma side usually exclude anything which suggests COPD or fixed air obstruction. Any study done in COPD always exclude any patient who has reversible airway disease, which looks like asthma. So this put in real world definition of putting a real world definition of ACOs is difficult because of really marginalization of patients who behave both disease entities. So then what is the difference between ACO and ACOs? So in 2014, as I said, was the first consensus definition of asthma-COPD overlap syndrome was clinched. ACOs was the name given. But subsequently, this is not the case. And then because of understanding of ACO, so the name ACO was reserved as well as compared to ACOs. So ACO is a preferred specific disease entity rather than considering as a separate entity. This is an overlap between two diseases. So this refutes a specific disease entity, and it emphasizes two disease conditions occur together rather than separate new entity. Okay, separate new entity. So the name ACOs is no more used now. ACO is the one which is preferred since 2018. So the name ACOs is removed from asthma-COPD overlap syndrome. So what is the clinical significance of ACO in this scenario? Why we are interested to know about ACO rather than really maintaining the different ACOs, or if there is difference between asthma and COPD, why it's not remain asthma and COPD rather than considering both diseases as ACO? So the most important thing is we don't understand when those diseases together and then overlap. So there are so many changes happening at individual level, at cellular level, when those diseases together occur. So there are limited understanding and also limited treatment options. The most important thing is patients who had both diseases had high risk of exacerbation and high risk of death as compared to patients with COPD alone or asthma alone. That's why we are more interested to know about ACO rather than just treating COPD and asthma. So really, this is something which really has clinical significance because it increases mortality, increases morbidity, increases exacerbation, and also increases treatment requirement. So because of that, we are interested to know ACO more as compared to treating COPD and asthma. So it's very difficult to generalize as well because of limited data, and also most of the studies, as I said, exclude this group of patients from the study. The asthma group also excludes this group team. The COPD team also excludes this group. So because of that, it's very difficult to know exactly what is ACO. So again, the prognosis of these patients are also poor as compared to other isolated asthma or COPD. treatment is they require increased treatment, and also the outcome is also poor as compared to asthma or COPD. So what is the prevalence? So the prevalence is estimated to be 15 to 45%, almost 50% of the case of chronic airway obstructive airway disease is attributed to this group. It's a very large group, but it's very difficult to know the exact prevalence of this disease because of marginalization of those patients from stages of asthma or COPD. So what is the pathogenesis of this group? So there are two hypotheses. The first one is the British hypothesis. The second one is the Dutch hypothesis. The British hypothesis says that two common diseases occur together by chance. Nothing else. This is occur by chance. Patient has asthma and COPD. The Dutch hypothesis says because of common risk factor, a patient develop asthma which progresses to COPD and then they develop asthma COPD. So the Dutch hypothesis says that which was the initial concept. That's why ACO was defined as a different entity. But since 2018, this understanding was become, people understand that this is not the case. It's not a different disease entity, rather it's an overlap of two diseases by chance. So the British hypothesis is the one which is well accepted now as compared to the Dutch hypothesis, which was initially thought to be the right pathogenesis. So this is how those hypotheses are derived. So the English or the British hypothesis says there are two disease entities occur together in the same patient. In case of Dutch hypothesis, because of common risk factors, and then patient develop ACO. So the one which is accepted now is more of the British hypothesis. So the etiopathogenesis of ACO, when you see, is just etiology of asthma and etiology of COPD generally come together. So in case of asthma, asthma is, we don't know the cause, but is an interaction between genetic and environmental factors like sex, body mass index, childhood infections, and then airway hyperresponsiveness, smoking, allergy, acute exacerbations during childhood, and then exposure to pollen, environmental factors. When they interact with genetic, individuals tend to develop asthma. In case of COPD, the most important thing is exposure to noxious particles and the gases. So smoking is the most important, biomass exposure, infection during childhood, genetic susceptibility, low birth weight, and nutritional deficiency contribute for development of obstructive airway disease, which eventually goes to COPD, and then when they overlap, they develop asthma COPD overlap. So this is a summary of clinical difference between asthma, COPD, and ACOs. So usually asthma, the age is at a younger age. Most of them develop before 20 years. And then COPD usually develop above 40, and then the typical age for COPD is 65 years, but ACOs is around 40. So any patient above 40, you should have to consider ACO and the differential. History of allergy is common. The patient who has background of asthma, and then asthma develop ACOs. Smoking history is quite common. The patient who has COPD, and also patient to develop ACOs as well. And then dyspnea, and then wheezing, those are characteristics of dyspnea is more characteristics of COPD, and then it's usually persistent in case of COPD. In case of asthma, it's usually paroxysmal or recurrent. So those are the summary of the difference between the three. So ACO presentations are increasing with age. As age increases, the overlap between the two diseases are increasing. So you should have to really consider in old ages differential. So what is the clinical description of or clinical presentation of ACO? In summary, usually the patients have above 40 or equal to 40 years of age. There is airflow limitation, which is not fully reversible. It looks like COPD. And then the patient has symptoms including exertional dyspnea, which persists like COPD. You have symptoms starting from childhood, which looks like more of asthma. And they have also personal history of asthma. They have also frequent history of exacerbations. And then they have symptoms get worse with time, and then they have also comorbidities. And then chest X-ray shows hyperinflation like COPD patient. So this is a mixture of both diseases, okay? Mixture of both diseases. So as I said, additional clinical points you should consider. Usually they tend to have more exacerbations. They have tended to have poor quality of life as compared to asthma and COPD. They have more decline in lung function as compared to asthma and COPD. They have more mortality. So you should have to really identify this group of patients and then optimize your management. So how to diagnose ACOs? So it's recognized as a coexistence of both diseases. So there is increased variability, which is a typical character of asthma with fixed air obstruction. So if you find somebody with variable airway obstruction with persistent obstruction or incompletely reversible air obstruction, you consider ACO. So patients typically have inflammatory process which looks like more of COPD. That's why they have fixed airway obstruction. So you should have to consider if a patient has overlapping symptoms of both asthma and COPD, ACO should be strongly considered. You should have to look relevant histories like age of onset, previous history of asthma, exposure histories, and also personal and family history of asthma. And also when you look to lung function, you should have to see if there is fixed obstruction or reversibility, and also if there is decline and then change in lung function, should have to be looked into. So the other is you should have to also evaluate sputum inflammatory markers. Okay, inflammatory markers in the sputum induce and the C, because there are some markers now developed to look for presence of ACO. And then biopsy. If you do endobronchial biopsy, you may find those inflammatory cells I showed you earlier. In case of asthma, you see predominantly eosinophilic inflammatory cells, but in case of COPD, you will see more of neutrophil predominant inflammatory cells at the cellular level with remodeling and structural changes in fibroblast. And then spirometry is very, very important to look whether there is obstruction, whether the obstruction is reversible or not, whether there is variability. So the whole issue is measured by spirometry. So you should have to do spirometry. The other is you should have to measure also lung diffusion capacity, which is quite normal in case of chronic bronchitis evolved with COPD, is usually significantly reduced in a patient with emphysema related to COPD, and then it's increased in asthma. And then the other is you can see structural changes in the lung with CT scan, and then if there is emphysema, you will see definitely emphysematous changes. So diagnosing ACOs is basically challenging. Even despite all those, it's very difficult to distinctly really diagnose what is ACO. So because of this, a global expert from Guinea and Gold come together and develop diagnostic criteria. So you should have to use this diagnostic criteria. So there are three minor criteria and 3 major criteria. So if a patient has 3 major criteria plus one of the minor criteria, it is enough to diagnose ACO. So the major criteria, you should have to find persistent airflow limitation, which means the ratio of FEV1 over FEVC is less than or equal to 70%. So this defines the presence of obstruction, which is not fully reversible or improved after bronchodilator. If it improves, usually this is asthma. But if it doesn't improve, this is COPD. So the first criteria I should have to consider is the reversible airway obstruction. Okay, if the airway is the obstruction is not reversible, particularly if the ratio is remain less than 70 after bronchodilator therapy. So this is the first criteria. The second criteria is significant smoking history. There should have to be risk for a patient to develop ACO. So more than 10 per year or equivalent exposure to air pollution or biomass exposure. So if you find that, that is also another major criteria. The third one is documented history of asthma or allergy or atopy or bronchodilator response for FEV1, not for the ratio. The ratio is already fixed. But if there is improvement in FEV1 by more than 400, which is very significant. This is also one of the major criteria. So the patient has fixed, persistent obstruction with improvement with bronchodilator of FE1 indicates ACOs more of rather than COPD or asthma. In case of asthma, we expect reversible airway disease with improvement in FEV1. In case of COPD, we usually expect both are low. The minor criteria, documented history of asthma or allergy. If you are not using this as a major criteria, you can use also the same. The other is bronchodilator response, which is less than the previous response, like more than 200 ml, and then 12%, 12% improvement in case of bronchodilator response of FEV1 in 2 occasions, not in 1 occasion. So if you document in 2 occasions, this can be used as a minor criteria. The other is a preferred level of eosinophil count more than 300. So this is a criteria because it's very difficult and delicate to delineate whether this is asthma or COPD. So if you come up with this criteria, I hope you can diagnose asthma COPD overlap. People now move to biomarkers from sputum to diagnose ACOs. So there are increased level of biomarkers in case of ACO, like chitinase like protein, interleukin-6, and the neutrophil, gelatin-associated lipokine. Those are some of the markers now coming into picture for diagnosis of ACOs, because in this group of patients, these inflammatory markers are significantly increased. So generally, those markers are developed for chronic airway disease and allergic diseases, but they tend to have high rate of increase, sorry, high rate of increase in a patient who has ACOs. The other is oxidative stress and mitochondrial dysfunction is also looked now. So the ratio of mitochondrial DNA to nuclear DNA is elevated in ACOs as compared to asthma, and then also as compared to COPD. So really, if you have level facility to measure those things, you may discriminate this. The other is some people also look into some genetic analysis like single nucleotide polymorphism. So there are some gene which shows polymorphism and then tend to evolve to ACO. So there are now genes identified, and then polymorphism of those genes may indicate those patients are at high risk to develop ACOs in the future. So this is also an indirect way of identifying the patient who may develop ACO or who has ACO at that point. The other investigation is airway disease, physiologic measurement of lung function. So as I said, in this group of patients, there is a persistent airflow limitation, and then this airflow limitation will be reversed. And then sometimes there is also good bronchodilator response, and they have also bronchial hyperresponsiveness. So if a patient fulfills this criteria, probably this is ACOs. So this is graphic representation of lung function measurement in asthma. Asthma is reversible. In most of the cases, it is reversible airway disease. Okay, when you give, there is obstruction. When you give bronchodilator, this is fully reversible. Okay, fully reversible, normalized. Okay, or there is improvement by more than 212%. So if that is achieved, this is called reversible airway disease. This is by far commonly asthma. There are also COPD patients who can show reversibility, but mostly reversible. COPD is in general irreversible airway obstruction. There is no reversibility in most of the cases. There are few individuals who may have reversible airway disease, particularly those individuals who has eosinophilic dominant inflammatory process. Okay, but in ACOs, there is irreversible airway disease with with good bronchodilator response, okay, or very good bronchial hyperresponsiveness. When you stimulate the airway, they react strongly, like asthma. So if you find this is usually ACO. So in simple term, if a patient has reversible airway obstruction with improvement in FEV1 after bronchodilator more than 80%, this is asthma. In summary, if a patient has irreversible, incompletely reversible airway obstruction, post-bronchodilator FEV1 is less than 80% still, this is COPD. But the remaining irreversible airway obstruction with very good bronchodilator response is ACO, and also irreversible airway obstruction with good bronchial hyperresponsiveness is also indicate ACO. So those are the groups, how to summarize. So management, there are difficulties in managing this group of patients. That's why I say this is a very contentious issue now. Still, there is no clear guideline to manage, to diagnose. That's why we based on criteria to diagnose this group of patients. But we know that this group of patients tend to die. They have high rate of exacerbation, and they have high morbidity, mortality. So because of that, we should have to really know more about this group of patients. So in terms of management, it's very difficult because, as I said earlier, most of standard management studies exclude this group of patients because they design for asthma or they design for COPD. Because of that, usually they are not included. So there is no really scientific evidence to support any kind of management in this group of patients. Rather, most of the management is expert opinion. Okay, expert opinion. There is no really randomized controlled trial to treat this group of patients. Rather, all what we do is just expert opinion. So the GINA and the goal come together and put some recommendation how to address this group of patients, and then I will show you. And then the patient with asthma, predominant feature, should have to start management of asthma. If a patient has predominantly COPD picture, it's better to consider COPD and treat COPD. If a patient has equal symptoms of asthma and COPD, consider ACO and then treat as ACO. So, because if you treat asthmatics with bronchodilator alone, you will kill the patient. If you treat again COPD patient with inhaled corticosteroid, again, there is a problem because you are not treating the proper way. So in asthma, the mainstay of treatment is inhaled corticosteroid. In case of COPD, the mainstay of treatment is bronchodilator. So that's why the challenge is, so the sources are different in terms of management. So when they exist together, we should have to consider the management of both diseases. So if phenotypically asthmatic, treat for asthma. If phenotypically COPD, treat for COPD. If there is equal number of symptoms of asthma and COPD exist, we should have to consider both and then consider the management of both diseases like inhaled corticosteroid plus bronchodilator together. So this is approach. So for a patient with COPD, the mainstay of treatment is bronchodilator. You can start with LABA or LAMA, or if a patient has severe disease, you may start combination therapy. In case of asthma, you start with ICS or ICS plus LABA. In case of ACOs, you should start with ICS, LABA, and then finally, if a patient does not improve, you go for ICS, LABA, LAMA, and then further you can phenotype the patient and then add other additional medications. This is a summary by Gold and Gina. The first thing is you should have to clearly define if the patient has chronic airway obstruction. If your answer from your history physical examination is yes, and then diagnose syndromic diagnosis. Put syndromic diagnosis. Is it asthma? Is it COPD or is it ACO from your history physical examination? So you should have to categorize this chronic obstructive airway disease, put syndromic diagnosis. And then once you did that, you should have to do spirometry and confirm the diagnosis. Are you dealing with asthma? Are you dealing with COPD? Are you dealing with ACO? And then finally start the initial treatment I suggested earlier. And then the answer is, if a patient fails to respond, additional treatment, and then refer the patient should have to be evaluated carefully by senior people. So this is the initial treatment I mentioned earlier. First line treatment for asthma, ICS or ICS plus LABA. For ACOs, ICS LABA, ICS LABA is possible. For COPD, bronchodilator is the mainstay of treatment. And then you can optimize by adding another bronchodilator. And then other non-pharmacological therapies like smoking cessation, pulmonary rehab is the most key element in the management of COPD. Add-on therapies, if the patient not improve, you should have to add. There are several lists of drugs which can be added for patients with asthma, like LAMA, theophylline, leukotriene receptor antagonists, and then monoclonal antibodies, anti-IgEs, and then also you can add prednisolone in our case. For ACO, you can use LABA, LAMA, and then also antiphospholipid, phosphostress inhibitors, and also theophylline, and then the list. And then again, for COPD, again, you can use additional treatment. If the patient fail, and then stage D, may add also ICS, particularly if a patient has eosinophilic phenotype, ICS may help. So the other additional treatment is anticholinergic. So people start to look into the role of anticholinergic in this group of patients. This is one of the studies which include a couple of patients and evaluated the role of tautropium, which is long-acting antimuscarinic, which is used for management of COPD. A patient who has an asthma with COPD, which is emphysematous change on CT scan, when they are treated with additional LAMA, there is significant improvement in terms of lung function as compared to those patients who has purely asthma. So this indicates patients with ACOs may benefit from addition of anticholinergic, unlike patients with purely asthmatic. And another is also, people add also omalizumab, which is anti-IgE. And though the sample size is very small, there is some improvement, even though the improvement is not statistically significant because of small sample size. There is some improvement. So this indicates that there is hope for also ACO patient to be treated by omalizumab and also other monoclonal antibodies. Another study also looked like another monoclonal antibody against interleukin-5, benelizumab. This is also one of the drugs which is developed for asthma. Now, one of the monoclonal which is used for treatment of asthma. This is also tried in some patients with ACO, and then there is some improvement, but still the sample size is small, and then small group of individuals are included, but the statistical value is not reached. But in the future, probably randomized large group study may come with a very good result, and then probably this group of drugs may help also in the management of this group, and then avert this frequent exacerbation and then days which occur in this group of patients. Additional interventions, one should have to look like if there are smoking history or exposure to biomass, that should have to be removed. So smoking cessation is very, very critical as COPD patient. The other is staying outdoor when a patient has, if there is really also exposure is a home. If there is air pollution, they should have to protect themselves from any kind of polluted environment. And then regular vaccinations with flu, like flu vaccine and streptococcal vaccine should have to be given regularly. And given complexity of ACO management and the risk of poor outcome should have to always assessed. And then at individual point, we should have to address each patient. So why has ACO become now renewed focus of interest globally? So the reason I mentioned earlier is this group of patients tended to die mostly. They have high rate of exacerbation. They consume most of the resources. So we should have to know about this group of patients. What is the best can offer? So because if you use the same trend like what we do for asthma and COPD, we may not change the course of the disease. So it's better to understand this group of patients carefully. And also some of the newer drugs are also working for this group. So since 2018, people start to use those newer asthma medication and also COPD medication for this group of patients. Before that, nobody was using those medications. So even though we don't have good evidence to support the use of those medications, but small studies show that there are improvements. So because of that, we have a very good interest for this group of patients. Additionally, as I said, monoclonals are becoming also part of the management in some countries for this group of patients, and then the outcomes also showing some improvement. But despite all, there is a long way to go still. We didn't understand the clear pathophysiology, pathogenesis of this disease. We don't have very good markers to diagnose because it's very difficult to differentiate. That's why criteria is developed. Even then, it's very difficult to claim this is really truly ACO. And then why those patients have also severe exacerbation, unlike asthma or COPD. Why? So we should have to know what is underlying really mechanism. Why existence of two diseases makes things worse. What makes worse? We should have to understand that. So we don't know that. So there is a long way to go regarding this entity. Even though this is not a separate entity rather the occurrence of both disease, but it is clinically very, very relevant. So the hallmark of my talk is this is clinically relevant, but existence of asthma and COPD named as ACO with clinical importance. So we should have to know in the future, probably we need evidence-based definitions, more detailed classification about the disease, and also underlying pathophysiology and why this happened, what are the physical characteristics of this group of patients, and then also broadly, how can you really classify and then diagnose this group of patients specifically using biomarkers, and then what are specific interventions which can prevent these days, exacerbations, and also poor quality of life in this group of patients. In summary, ACOS is prevalent among chronically obstructed patients, so you should have to consider a new differential if a patient is above 40, came with exacerbation, frequent exacerbation, if the quality of life is poor, if a patient has persistent symptom with reversible airway. Other is obviously the diagnosis challenging, and then it is not a single disease, rather it is an overlap of two diseases. So genetic and molecular biomarkers probably help to identify this group of patients best in the future. So the most evidence shows that use of medications based on dominant feature is a picture, like if dominant feature is asthma, treat for asthma. If the dominant feature is COPD, treat for COPD. If you think both exist, you should have to treat as ACO. Other treatment options like omalizumab and other management for COPD and asthma probably has a role in this group of patients in the future. We need more data regarding the use of routine use of those medications. This is what I wanted to say. Thank you.
Thank you, Dr. Amsalu, for the excellent presentation. I think this problem, we don't usually recognize it, you said it may be highly violent because some of our patients who were diagnosed as asthma may turn out to be as you have witnessed in our study. 1/5 of our patients COPD better also. There may have been asthmatic for some time, may have environmental exposure. In our case, it's maybe the biomass fuel and something like that because the smoke is low. So I think it's good to recognize such group of patients, and it can help also for study purpose. Elsewhere, I don't think it's a fine study for this group of patients because they may not have enough data or something like that. But if you collect this data separately, we can, undergo study this group of patients, and also it's they'll be benefit from the treatment. And what's not clear for me here is that I thought that the approach should be somehow, patients where there is ACO should be managed as asthma for any practical purpose, because omitting, only giving bronchodilator may put this group of patients at high risk for exacerbation and death, as we know, if you put them only on Java or Lama. So, but in your presentation, you were saying that treat them as which symptoms predominate. So, what is your final verdict on this? Shall we treat them for all practical purposes, even though they qualify the diagnostic code, which I like the criteria? I never knew that criteria existed. So once we diagnose them, shall we manage them for the predominant symptom, or for practical purpose, it's better to manage them as a case of asthma? Which one do you say?
Yeah, this is a very critical question. Excellent question. So, as you say clearly, initially for practical purpose, ACOS was basically if you diagnose ACOS, not miss asthma, you should have to treat as asthma and then add bronchodilator. But now, from both ways are possible. From asthma to ACOS, from COPD, ACOS are possible. That is a true understanding now. Patient may develop asthma during childhood, and then after 40 years, they develop COPD and then develop as ACO. There are patients who develop again COPD and then develop ACO, hypersensitivity reaction, allergy. Then usually asthmatic above 40, they tend to go into ACOS again. So this is a new understanding now. So when you treat this group of patients, the first thing is what is the dominant feature? If it is asthma, it's better to treat asthma. If it is the dominant feature is COPD, if there is no eosinophilia, treat as COPD. If there is equal number of symptoms for both, and then you consider ACO, and then treat with both diseases, ICS plus long-acting beta agonist or LAMA. So the understanding is from both ends possible, and then even though most of them are just patients known to have asthma and they develop COPD after the age of 40. But there are also patients who develop ACO from COPD pool. That's why you should have to consider. And then that's why the understanding is still blurred. And then initially for practical purpose, this group of patients even put as asthma. So it is part of GINA guideline. But now this is not only GINA. GOLD also puts this as a separate guideline. And then usually they release on a consensus guideline now. They put consensus guideline. The expert panel, which is just put the criteria, is also just came from both teams. Equal number of teams came together, and then they suggest this kind of management. So this is a really clear point. And then for practical purpose for us, you should have to treat both together and then give ICS, because the worrisome is if you treat a patient with asthma with long-acting beta agonist alone, the SMART trial, probably you may remember, the patient may die because you overlook the inflammatory process, you treat the symptom, the ongoing inflammation get worse and the patient die. So you don't treat asthma with bronchodilator alone. So always ICS is the initial treatment, even in ACO. And then you add long-acting beta agonist or LAMA, whatever you want.
Thank you. It was an excellent presentation. The question is, in one of your slides, you have mentioned in the molecular diagnostic part, there are certain polymorphism of certain genes. Then if that is the case, don't you think this ACO is, if it has a polymorphism, meaning it has a signature, so don't you think this is a specific disease entity which supports the Dutch hypothesis
British hypothesis? That's a really excellent question. This is also one of the debates. So there are some patients, yes, they did some polymorphism and that identified this group of patients tended to have some sort of ACOS-like picture. So nobody is sure, but this is the level now. They start to identify some few genes, and then polymorphism is identified, and then those groups tended to have this kind of presentation. So that's why people are now still working on it. We are not sure. And then there are multiple genes which shows polymorphism in this group of patients. The same is true in asthma. The same is true also in COPD. So in general, asthma is, even though it's partly genetic, there is no single gene in asthma also. There is the same polymorphism, different polymorphism. All those polymorphism also happen in asthma, by the way. And then some of them have been shared in some patients with COPD. Those genes are shared also in some patients with COPD. So yes, I agree. That's why still there is a debate. But phenotypically, the British hypothesis is now more accepted than the Dutch hypothesis. And then the Dutch hypothesis was the initial thought. And then this is distinct disease entity which evolves with some risk factors. But now the understanding is rather than so still both theories are accepted, but more now since 2008 is completely shifted to the hypothesis of British. By chance, they occur together. And then when they manifest, there is also polymorphism occur. When those diseases occur together, there are some genetic polymorphism occur. So in the future, probably we may have true understanding of the disease. This is a very new and then limited research is going on. And then in the past, and then recently this is open for research. So I hope there is much interest now to understand, because most of COPD who died, most of asthma who died have this phenotype. So that's why people now look into it and then figure out why this happened. When two diseases occur together, why a lot of patients die? Why they require a lot of medication to treat? Why they develop exacerbation? So I fully agree. In terms of genetic, if those are identified, it's quite, it goes, but phenotypically, what is accepted is a British.
Thank you, Dr. Amsalu, for explaining this. So can we say this is a new disease and a new category? And the second question is, there is phenotypical eosinophilic COPD.
Yeah.
So could this be Addis?
Some patient has, I will start from the second question. Some patient with COPD has predominant inflammatory cells of eosinophilia. They are COPD patient, but they have predominantly eosinophilic cells in the inflammation. So this patient tended to have reversible airway disease as compared to COPD. In COPD, we expect fibrosis, remodeling, and then usually the inflammatory process is caused by neutrophil, which is very aggressive, and then also cytotoxic T cells or CD8 lymphocyte. So this causes structural damage. So by the time the patient develops COPD, there is fixed air obstruction. The patient may have emphysema, the patient may have chronic bronchitis, the patient may have smaller airway disease. Those are the three disease categories which end up into COPD. So by the time they develop structural change, and then we level, once they develop obstruction, we call it COPD. Before that, they are not labeled as COPD. But some of them, this group, the mediators are eosinophilias, rather than neutrophils, rather than other cells which are participated in COPD. So eosinophil is basically inflammatory cells in asthma, predominantly. Most of the patients with asthma have eosinophilic inflammatory cells. And then there is also type 2 cells, type 2 asthma, we call it, which is mutated by type 2 lymphocyte. So because of that, those patients show reversibility. That's why now eosinophilic phenotype of COPD, they benefit from treatment with ICS, steroid. They responded to steroid, and this group of patients, really there is marked improvement in terms of lung function, in terms of outcome, if you treat with ICS. Addition of ICS is recommended for this group of patients. But if a patient fails to respond, in our case, where we cannot measure the eosinophilia level, usually in the patient stage D, so we classify COPD into A, B, C, D. So stage D, we usually give ICS. LAMA, LABA, and then finally we add ICS. So that's what. The first question is the disease entity? That's the question, you see. So is it a subparate disease entity? The issue is this is asthma, COPD overlap, and should have to be recognized. But we cannot say this is a new disease entity. So initially it was considered as a new disease entity. Syndrome is a different disease entity, And then the Dutch hypothesis was the one which is accepted more. So this is a different entity which has behavior of asthma with behavior of COPD. Now the understanding is not the case. Rather, two diseases occur together. So is different phenotype of asthma or phenotype of COPD rather than different disease entity. That is a consideration. Probably. In the Zano, in the Zano. I think so. We don't have true understanding.
Thank you very much. How difficult it is to treat these patients. So we see because we have one patient in Europe, history of asthma, he also HIV patients, and on top of that, he has bronchial cancer with pseudomonas. So all these diseases are possible in an individual, and it makes it quite difficult, especially if you consider diseases that begin with symptoms like asthma, high dose steroid, worsening of bronchial gases worse, and we have seen that in it has been use of steroids, markers. So honestly, thank you for showing us the diagnostic criteria as major development. Should be practiced and should think of this disease as part of a systemic disease, because mortality with a likely including COVID patients. Have a fair aim as a viral infection, for prevention for pneumonia, COVID, other holding out bronchitis. Just to say about molecular markers and so on, asthma by itself is infectious, let alone when you overlap with so that's why managing asthma is difficult, because at the end now the move, as you well know, difficult to treat asthma from your study as well, right? So the move is targeted therapy because it's very heterogeneous. And the pathogenesis, the molecular markers, now the move again is on the epithelium, because all the external stimulus go to the epithelium and then induces all the different cellular markers. So when typing in asthma, you start the endotyping, is molecular subtyping, and then also cellular typing, and then comes the phenotype. So what we should emphasize for our setup is what you present as phenotyping. Also knowing that it is a heterogeneous disease, and syndromic approach might not suffice.
Thank you.
Connected to the first comment, I just find that some of these patients they have TB in the past or something like that. Is that possible?
So that is a very new concept we should have to look into, because most of the ACOs is derived from ambient air pollution and then smoking related COPD. Previous TB, other cause of COPD in general, nobody looked into even to that. So really, this is one of the areas we should have to look. What are our patients? So we have a lot of patients with TB who develop COPD. So obviously, TB is now become one of the risk factors. HIV is become one of the risk factors for COPD. So how this patient, when they overlap with asthma, how they behave? Probably what she says right. They have probably the worst prognosis for sure, definitely. So let us look at that. So somebody will take it and then look into it, and then, yeah, you can characterize. It is really one of the areas we should have to work and then come up. And then what I know is most of the COPD component is studied based on COPD related to smoking and then air pollution. There are a few studies now coming with COPD in low and middle income countries which focus on TB and then biomass.
Thank you. announcement from the department. Okay, so our department had conducted a staff meeting on November 2, the last Wednesday, on its 836 meeting. It has selected the two presidents for coming 1 year, and there were 8 shortlisted candidates, 3 females and 5 men. And from that, we have come up with the following 4 lists, 4 names. And as I call, please come to here so that everybody knows you. And we have selected Dr. Hannibal Kasahun to be the chief president. Okay. Just I'm not dramatizing it as Oscar and other, but number 2, second, I think I should have started from the last. I would have started. Okay, the second is Dr. Bamlak Andargacho. The third chief president is Dr. Freyot Ababa. And this is the group of these 4. And the 4th is Dr. Ibn James. So there were good competitors also, but particularly when we selected the 4th, there were 3 people who were, the same result, but finally we come up with this. I would like to congratulate you. I think a lot of hard work will be just waiting for you for the next 1 year, and you are expected to do that, to accomplish by dividing the work among yourselves, and the department will support you and wish you a good academic year and leadership role. Thank you, and please give them a round of applause.